We will illustrate the percutaneous correction of hallux valgus with hallux valgus angle of 46 degrees, intermetatarsal angle of 20 degrees, and distal metatarsal articular angle of 30 degrees, subluxated, incongruous, associated with crossover deformity of the second toe. By means of percutaneous extra-articular reverse L proximal chevron, PERC, osteotomy, with a plantar arm longer than the vertical arm, stabilized with a metallic bioabsorbable screw called magnesics. We will use a percutaneous instrument set, which is composed of a handpiece attached to a high torque and low speed motor. During the surgical procedure, 3 different burrs in shape and dimension will be exchanged at the tip of the handpiece. As we start the procedure, we position the first needle at the level of metaphysis of the first metatarsus to identify the exact level and the exact direction of the vertical arm of the osteotomy. With the second needle that is parallel and inferior to the first one, we identify the proximal end of the plantar arm of the osteotomy. With a 64 beaver knife, we perform the first skin incision within the distal needle, and we proceed with an accurate detachment of the capsule from the sclerotic plane. The insertion of the first burr must be very precise, as it delimitates the superior edge of the osteotomy and determines the direction of the translation. It will be introduced at the metaphysis, at the point where the head meets the shaft of the first metatarsal bone. The direction in frontal view must be 90 degrees to the second metatarsal bone to limit the shortening or lengthening of the first metatarsus. In sagittal plane, we must incline to 10 degrees the direction of the burr in order to let a slight plantarization of the metatarsal head and to avoid the overloading of the second metatarsus. The radioscopic control confirms the exact distal limit where we will start our osteotomy. We proceed with the second skin incision at the level of the other needle. With a small rasp, we move away the soft tissue and we identify the superior and inferior edge of the metatarsal diaphysis. We introduce the second burr parallel to the first one at the inferior cortical edge of the diaphysis as plantar as possible. We perform the radioscopic control to verify the exact position of the burrs, and we start the metatarsal osteotomy, first the plantar arm, moving the burrs on a horizontal plane, one towards the other. We reposition the burr at the distal extremity of the osteotomy, and we proceed with the dorsal osteotomy, moving from side to side, from lateral to medial. Once the osteotomy is completed, we introduce the first lever inside the medullary canal, and we start translating the metatarsal head, slowly giving tension to the hallux adductor tendon. We insert a needle at the lateral limit of the metatarsophalangeal joint that will serve us as a guide as we introduce the 64 beaver knife. At this point, we change the thin lever to a thick Kelly lever, and we begin to translate the metatarsal head in the lateral direction. We introduce the Kirschner wire tangential to the medial cortical wall of the proximal phalanx, pushing until it reaches the Kelly and pushing it then to the medullary canal. We control by radioscopy the correct introduction of the wire in the medullary canal and correct translation of the metatarsal head. At this point, we proceed with the stabilization of the correction by means of the same percutaneous burr that performs the entrance hole for the screw. The hole is positioned 2 centimeters proximally to the introduction point of the lever. We drill the screw canal, controlling its course in radioscopy. With the burr that reaches the cortical edge of the metatarsus head, we measure the length of the screw to be inserted by subtracting the burr length outside the bone. Once the burr is removed, we introduce the guiding wire, and after controlling its exact position, we introduce the Magnesics absorbable screw. After radioscopic control of the right correction of the metatarsophalangeal subluxation of the first axis and the optimal translation of the metatarsal head, we complete the operation performing the Akin osteotomy of the proximal phalanx. In order to do that, we introduce the burr in the medial-lateral direction at the level of the proximal metaphysis of the proximal phalanx, perforating the medial cortical wall and reaching then the lateral cortical wall that must remain untouched. We proceed cutting the plantar cortical wall and then dorsal cortical wall. You must be very careful to keep the burr inside the bone, as there are high risks of hallux flexor and extensor lesions. We proceed at this point with the regularization of the exceeding medial metatarsal prominence. We complete the operation performing the correction of the crossover second toe deformity with percutaneous tenotomy of extensor longus and dorsal capsulotomy, flexor longus and brevis tenotomy via plantar approach.